Hi, I'm Tim Wiedrich with the North Dakota Department of Health, Emergency Preparedness Response, the Health Resources and Response section. Thank you so much for joining us for the statewide meeting regarding long-term care. We have a few items to walk through, and obviously we're going to get to your questions in just a few moments, but let me turn to Shelly Peterson now and see if Shelly has any opening comments. Go ahead, Shelly.
Hi, thank you, Tim. I just want to say thank you to all for this last week. I know it's been horrendous with all the testing that's going on, and just wanted to confirm that all 218 long-term care facilities are scheduled or have completed testing, and we know that testing, having done, many of you gone through that process, it has generated a lot of questions, a lot of issues. And so at this meeting,
you can feel free to come
I think
up
on your
to
agenda,
this corner.
we have Dr. Stahl joining us to answer a lot of those questions. So I just wanted to say thank you for all of your support in getting your residents, your tenants, and your staff tested. We know that that is a great undertaking. We know that it may continue for a while, and we know that there are lots of questions. So we hope to have a really good discussion on that topic to start our meeting today. But welcome to the call this week.
All right, thanks, Shelly. Well, let me go ahead and lead off with the very first topic, which is a testing update. Many of you may have seen the health alert message that went out yesterday, and there was actually two messages. The first one had an error in it, and this was to basically provide some information about a new program called the Community Health Testing Initiative. And the idea is that this creates some bandwidth to obtain testing results from local health departments so that they can help determine at a local level, not just the state priorities, but at a local level, what the needs are for that local community in testing. And then also another major partner of that are the critical access hospitals. And unfortunately, in the first email that we sent out, we inadvertently had indicated that there was a capacity of 1,000 tests per day, and that was not at all correct. Shortly after, a few hours later, in a correction health alert message went out, and the actual capacity is 300 per day, or 1,500 per week. Now, we anticipate that as the program continues and as we build more lab capacity, we'll be able to dedicate more of the laboratory bandwidth to those types of local initiatives as time moves forward. But I just wanted to draw your attention that there was an error in that very first health alert message in terms of the quantity that's available. It is in fact 1,500 a week. Let me see if Vanessa has any additional comments about testing. Go ahead, Vanessa.
I just wanted to say that I did send out in the handouts some updated guidance, and I spoke with Joe Vetter, or I was emailing with Joe this morning, and he said this is a very fluid document, but I wanted you guys to know that right now you just have the one spreadsheet to do, the one that has the names of each person, the test request, and just make sure you read through that guidance. And when the schedulers send out guidance, just make sure that you always follow what they say, because this could be changing basically on a daily basis. So I just wanted you to have that, and keep in touch with me if you have any questions regarding testing in your facility. So that's all I have, Tim. Thank you.
Thanks, Vanessa. I'm not seeing Dr. Stahl online with us, but let me just call out in case he's someplace that I'm just not actually seeing him right now. Dr. Stahl, are you with us? I'm not hearing from him either. So we'll go ahead and move on to the next agenda item, which is the Committee on the Reuniting Families Task Force. As many of you are probably aware that there was a recent release of CMS guidance on the visitation relative to long-term care and some of the things that CMS is indicating will need to happen in order to cause an opening of visitation. And there was an initiative as well prior to our awareness that CMS was going to issue this guidance about a state effort to launch as part of that process as well. And so we've got a few things to talk about in terms of where we're going relative to opening up visitation within the state. And so for that, I'll turn it over to Shelly.
Thank you, Tim. As we have sent out to you, we are in the process of forming a statewide task force. We talked a little bit about it on last week's call. Chris Larson was on the phone with us, who's our chair. He is a resident at in Mayville, and we're excited to have him on board. We're excited to have him lead the charge. And this task force and group was created before we knew that there was CMS guidance coming out. I guess that took me by surprise and anticipate that it was going to be out. And what we're trying to do now is work very closely with the Department of Health, because CMS gives them all the guidance letters, and then they come to us and they know, or they come to you and they expect compliance. I've never seen before, and it's refreshing, I think, that CMS is giving potentially flexibility to the states. So the states have an opportunity to look at their specific situations, make sure you comply with the CMS guidance, to give you flexibility on how we're going to reintegrate families into families with residents. So it's exciting to have that. It's a little bit nerve-wracking, but it gives us all kinds of flexibility. Originally, when we put the task force together, and it really was the brainchild of Chris Larson, after a radio show, I think this last week or the week before last, that said, Shelly, this is such a big issue statewide. How about if there was a task force? So we got very much on board. We think it's the right way to go. We're involving families, residents, state government, and the governor's office, and we think it really will have some good outcomes that are safe. I think everyone on the group really feels a great need to reunite and have visitation, but we want to do it safely, and we want to do it right, and we want to do it and meets the needs of families, residents, and facilities, and the government, because we're still learning about the virus. We're still not sure if we're going to have a second wave, and we don't want to suddenly open up in not a good measured way. Part of that is we're going to learn from what we did. Rugby, as we shared with you last week, developed the compassionate care guidelines. So we know that there's that there's some out there. I know that Chris is reaching out to residents and families now, getting their input, getting their thoughts, getting their ideas. We also have some legislators on the work group. But one thing that we've done is we've grown tremendously. I think we have 25, maybe we might approach 30 people on it. But I decided I have a hard time saying no to people that want to be involved in such an important issue. We're going to be doing it virtually, but our goal, the governor had mentioned last week that he was hoping for some guidance at their level relatively very soon. And then I heard recently that, given that we're having some more positives, we need to take a really measured approach. So we're hoping to have a document for you as all members to review as we develop this guidance, get your input and your thoughts. So if you're not serving on the committee, I want to assure you that your voice will be heard, and there will be opportunities for you to look at it and see how it would work in your facility. And we would welcome that input. We were hoping initially that our meeting is next Tuesday, and maybe by Wednesday we would have something, a draft of something. I don't know if that's realistic. I don't know what we'll accomplish in that first meeting, other than that is our goal. And so we'll communicate out to you where we are with that. We'll keep you involved, and we'll solicit your input. And then we'll work very closely with the Department of Health, the Department of Human Services, and the governor's office, so that we have guidance that works for all and is accepted by all. Accepted in that we have agreement and consensus, and this is the best approach for North Dakota. So with that, Tim, I think that's all I have. I know that there are others on the phone that are part of the work group. I don't know if Chris made it on, if he had anything to add. Our first meeting again is next Tuesday. Originally it was Wednesday. We moved it up a day because of the importance of it and the desire to get some guidance sooner than later.
Well, let me go ahead and call out if you are anybody that might be actually part of the presentation, so Chris Jones or Caprice or anyone, and you're on the phone, which is 855-361-4591. That's our question and answer one. But right now, if you did happen to dial in on the phone, Chris or anyone else, hit star and then pound, and we can go to you and get your comments. I do see that Dr. Stahl has joined us on the video conference side. And so while people might be organizing on the phone, let's go ahead and hear from Dr. Stahl to see. Dr. Stahl, do you have any comments to update us on the testing process?
Thanks, Tim. Can everybody hear me? I know we had some technical difficulties just a second ago.
No, we're hearing you loud and clear.
Excellent. I wanted to maybe just make some clarification statements about just a couple of items. Having been involved in this process, the state of North Dakota finds ourselves in a very unique position, such that we have the capability to undergo testing of vulnerable populations, which many states don't find themselves in. So I think that's to one point is really a win for us in North Dakota. With that, part of our strategy has been to test the vulnerable population, which is long-term care facilities where people might not have anywhere to go should they end up having the disease come to them. So being able to identify and test those populations, I felt was of value and importance. To speak to accuracy of testing, when we look at the platforms that we have at the state lab, which includes the Abbott M2000, the Kingfisher from Thermo Fisher Dynamics, the Hologic Panther, and then in future, the Abbott Alinity, we are talking about the gold standard of testing strategy of care. This is where everything gets based off of. When it's positive on those testing platforms, there is no additional test that can be really performed at this stage in the game to refute or deny that legitimacy. To speak to the Abbott ID Now as a mechanism, we know that there are accuracy and validity errors associated with the Abbott ID Now platform. What that means is that if there is a positive from an Abbott ID Now, we know that it is absolutely positive. You definitely have the virus and you are actively shedding it, and the genetic material that we're finding is absolutely there. We don't have antigen testing online and approved yet, but we're in the process of working on that. If you have a negative test from an Abbott ID Now, it doesn't mean you don't have it, because there are a lot of quote unquote false negatives associated with that. And if you go to the Department of Veterans Affairs or the Indian Health Services, they've established policy guidelines regarding this. We know this, and we've looked at that. So to use that test is fine to do, with the understanding that it is not necessarily accurate if it ends up being negative. Our statement and assessment from the state lab side is that if you have a high index of clinical suspicion that it is there, you should retest on another platform to avoid that false negative aspect. The reason why we are going through and doing testing of these facilities is to elevate the awareness that this disease is there and we don't even know it. And we have some aspects to say in the state of North Dakota that with the genetics of this particular virus that we are seeing possibly one of two things. One being the fact that the other coronaviruses, which there are 7 in total, might have some level of cross immunity. So in other words, we know that SARS and MERS are not in our facilities because people die right away with those. With SARS-CoV-2, we're learning a lot about this virus, but there might be some cross immunity with the other 4 clinically insignificant coronaviruses. If we look at that even a step further, the virus that came out of Wuhan went to Lombardy, Italy, to King County, Washington, to Connecticut, and the way it made it into North Dakota may also play some role in that this virus is regressing to the mean, so to speak. So it's there, but it might not necessarily have as large of a clinical impact as it's had in other states. We're learning about this. We're actively investigating it. It's going to be a process that we move forward with to help have a better understanding for North Dakotans and for long-term care facilities, because it's going to change. I worry about the fall and September, October, and the double whammy that will happen with influenza. And we need to be prepared for that. And we need to have a plan in place for long-term care and a testing strategy in place, and how we're going to help mitigate this when it comes this fall. I think that will close my statements unless there are specific questions as to which I can answer.
All right. Thanks, Dr. Stahl. And we'll be coming back into question and answers in just a few moments. But for right now, let's see if we have Chris Jones or anyone else that has some additional comments over anything that we've covered so far. Well, let's go ahead and proceed then on the next area of the agenda, which is Shelly Peterson back to talk a little bit. Roseanne Schmidt is next, and that's to talk about the long-term care dashboard on the Department of Health website. Roseanne?
Yes. In Tim and actually your team, you probably could answer it as well as I can, but I happened to have a conversation with Molly yesterday after we had worked through what we would propose to see on the public website for positive residents in our facilities. And so I think the team has come up with a plan, and we're hoping as early as tomorrow that Molly thought she'd be able to have it online. So the topics or the areas that she will be posting, like it is before, the city, county, facility name and type of facility, and number of licensed beds in the facility, and then current number of positive residents and current number of positive staff. And that is going to be it for the website, as far as I know right now, that is proposed. So Tim or Kathy, anybody else on your team have any other thoughts on that?
I don't have any additional. Kathy, anything more to say on that?
No, I think that, no, I don't have anything else.
Roseanne, this is Shelly. Could you clarify, because I love this statement. I was hoping to have staff off, but I love the statement that you said, current number of positive residents, positive staff, because that's, right now it's an accumulative number, so it's a really high number. So how will people be taken off that are no longer active? How is that going to work?
Well, that was a discussion, and anybody else that's on the call can jump in. But I think that CDC has made recommendations that disease control has adopted, that after 10 days of a positive test, it is going to be automatically coming off. And so they are going to do that in their process when they review the data every single day. The positive results, anything that comes in, Molly, Miranda, whoever else in disease control, they manage that. And so then they will change the numbers accordingly and then get it posted on the website or get it ready for posting.
I guess the other thing that
that helps a lot.
That is that part of the discussion was also that while deaths will continue to be reported, they'll be reported as a cumulative number for the entire state rather than by individual facilities.
Or even, I'm not sure, was it going to be on the website at all? I wasn't sure if that was finalized at all. I think it'll report it in the statewide data, but not as part of the long-term care facility part of it.
And that could be accurate, but we do know that we will have questions about the total numbers of deaths, but they won't be reported as the bigger point by individual facilities. All right. Well, we look forward to more information about that as that becomes a reality and that gets stood up tomorrow. I think that there are a number of areas that you have been requesting that have in fact been addressed, and that it should be, I think, for the most part, viewed as an improvement by you. Let's go ahead then and now move on to the stimulus checks for residents in the nursing facilities and basic care with Shelly.
Thanks, Tim. I just wanted to very briefly talk about this and first give recognition to Caprice. Originally, when the federal government sent out the stimulus checks, we became aware of that basic care residents weren't going to be able to keep their stimulus checks because of rules North Dakota had. And we recognize that because North Dakota has a unique program that the rest of the country doesn't have. So even though nursing facility residents were able to keep their checks, basic care were not able to. Caprice immediately considered the issue, understood what the issue was, and immediately began talking with Chris, with the governor's office and others, and really was instrumental in bringing forth change. So I just wanted to say thank you to Caprice and the department for working diligently on that issue, because I know that it took a lot. We had many legislators too that were supportive of the state in making changes and supportive of coming out with the emergency rule. So number one, thanks, because that you tremendously impacted and brought joy to a number of basic care residents. They are having fun learning about how they can spend the money. Spending the money is another issue. I know that we sent guidance out from DHS from Joyce Johnson for basic care facilities. So make sure you look at that, because it has kind of the same rules a nursing facility does. You must spend it within a year. But a new issue or wrinkle that just came up this morning was the Medicaid fraud unit. Medicaid fraud unit has received 2 complaints, 2 concerns on their website about about facilities taking that stimulus money and not giving it to residents. Now, those, just know that those are allegations. The Medicaid fraud unit is investigating it. They really believe, based on their initial investigation, that it really is an issue of not understanding, no wrongdoing occurred. But and to me, I'm thinking it might be related to basic care, because basic care residents were initially told that they weren't able to get the money. And so I just wanted to assure you, if you have a call from the Medicaid fraud unit and they say they're investigating you specific to this issue, just make sure you give them the information and the understanding that you had. I've given them all the information that we got from DHS on the nursing facility checks, stimulus checks, and how to handle them, as well as the basic care one. So I'm sure everything will be cleared up. Don't panic if the fraud unit calls you. They're great and wonderful to work with. And I think through communication, everything will be cleared up on that issue. So I think, and that's all I needed to say, unless there are questions.
And again, we'll pick up the questions when we come back around through the question and answer portion.
Right.
So let's go ahead and move into the next topic, which is healthcare standard. I know that for a long time we've been using healthcare standard in this state, initially with the hospitals, and now more recently incorporating, even outside of COVID, healthcare standard is a tool for collecting information from long-term care as well. But it's taking on some special utilization for collecting information now as part of the COVID response. And so we have Caprice Knapp with us from Human Services, and Ryan Dreher, who's with our Emergency Preparedness and Response area, to talk about this. So Caprice, I'm going to ask you to kind of give a high-level overview in terms of the data that's about to be collected, and then Ryan to follow up with some of the more technical details about the Health Alert Network and specifically this healthcare standard process. Caprice?
Sure. And Tim, is there any way that Ryan would be able to share his screen or no?
Ryan, are you in a position to share a screen? Ryan, I think you're muted.
I can go ahead and start. Oh, go ahead.
I will start sharing my screen now. Hopefully you can see it.
It's in the process of coming up, Ryan.
There we go. Okay, so while Ryan is getting set up, I'm going to just set the stage a little. So you all know, and you've been working with us over the last couple of weeks on this daily data collection tool. And this has been an ever-evolving process. Thank you to everyone who has provided feedback to myself and Vanessa on, clarity on some of the words, the definitions. I also sent Vanessa today a revised FAQ so that you can see some of the questions we had from folks were about, what time do we have to submit this? We had originally asked for it at 9 in the morning, and now we've moved that back to noon Central Time. So that'll give you a bit more time to, come in and get settled and gather that information. We received feedback from you all about on the weekends. Do we need to do this on the weekend? And if I have included information on the FAQ that basic cares and assisted living facilities do not need to do this on the weekend. We know that if we get ourselves into a surge situation, that might change. But for now, we feel comfortable with a Monday through Friday. And then also we received individual feedback from a lot of you, and it's been really helpful about, again, not just the words, but, trying to really zone in on, making sure that everything is clear. On the back end, I can tell you that it also has been a heavy lift to coordinate across all the different groups that are looking to use this data in different ways. And I won't go into the gory details on that, but just to tell you that we've been trying to balance out the needs of folks who need the data versus cutting back as much as possible to relieve the burden on the facilities. And so just as a high level overview, we originally started this out, we had about 50 questions, and now we're down to the high 20s. And then I'll talk to you today about, there's even about 6 or so of them that you're only going to answer one time. So as Ryan has the screen up, I'm going to point out some of the major changes between the last time you saw this and now. And so first thing is, let's go to the screen, Ryan, that has the tabs. I don't know if you're able to do that, which shows beds, staff, resident movement, and testing. Let's see if we can get to that. Okay, so if you look on the top of the HC standard in that grayed out box, you see we're on beds now. And you see it says beds, resident movement, daily testing, and testing baseline. So again, we cut back several of the tabs. Remember, we had some healthcare tabs that were about, are you following CDC guidelines? Are you isolating? That tab is gone. We had another tab that was about supplies. Like, do you think you're going to run out of masks or gowns? Or that tab is gone. We had a staffing tab that is gone as well. So we've tried to, again, cut this back as much as possible. You see the beds tab. I'm not going to go through that. Those are pretty consistent with what we were asking before, which is, your total number of beds and your how many are occupied. If you move to the resident movement tab, please, Ryan, here is where you can see, I'm not going to read through each of these, but some of the changes we made here, people were asking specifically about, let's let you do some work in there. People were asking specifically about what is 24 hours, what is yesterday, what is so we try to clear all that up. So if you see every time in here it says yesterday, we define that as midnight to midnight. So we had some great questions. For example, one that came in yesterday, which is like, well, what if I fill this out at 4 and it's saying in the last 24 hours? So we cleared up all those time frames where everything really is focused on a midnight to midnight. And that matches up nicely with what we're asking for on the hospital side as well, because that's the way in which they measure. I won't go through these, but Dr. Stahl worked with us and gave some great input on this. And this is really about as you're moving people back and forth, both to the hospital, to another facility, and to the home and community, trying to get a handle on how many of those folks are positive, both on the transferring side and the receiving or the admitting side. Again, you know, we don't expect that these numbers are going to change much on a day-to-day basis, but you'll be answering this from midnight to midnight. Okay, so let's move now to the daily testing tab, Ryan, if you don't mind on that one. Now here again, so we had originally started out asking about tests, and you guys had some great questions. You said, you know, well, what if I have somebody who's got multiple tests? What if I have somebody, you know, how do I deduplicate that? And so what we've really focused on here is, again, everything is about yesterday, which is that midnight to midnight time frame. And we're asking for your residents and staff, the positives, the recovereds, and those who may have passed away. And then specifically on those who have passed away, we want to have that carve out of or any of them on hospice or comfort care. So again, this is sort of like your daily ticker. So this is not the cumulative number. This is anything that happened midnight to midnight. And again, you know, you may not have any changes here, and this is all going to auto-populate for you from the day before. The testing baseline one is where I think we really want to spend some time and do a bit more explanation. So if the daily testing is doing a tick and adding, right, because, or sorry, you're telling every day what happened, we have to start from a baseline. And so the testing baseline will start on the 25th of May. I realize that that's Memorial Day. I realize that, but it needed to start on a Monday. And so the testing baseline, and Ryan, if you can click on that one, that's really about up to this day. What's the total number of staff? What's the total number of residents that you've had positive, recovered, or died? And again, we say, what's the total number of staff that are positive? And what's the total number of staff that have recovered? You know, those are unique numbers, okay? And so this develops your baseline, and you only fill these questions out one time. You're not going to touch these again. The daily test, yep, that'll just tick from day to day to day. But the baseline, only do one time. We're asking that you try as best you can to do it on the 25th. And again, we've extended the time for that. We'll work with you as much as we can, but really that baseline is sort of where we start from. And then the daily testing is what's ticking you from day to day to day. So again, added some FAQs to clarify some of this, giving you as much time as possible, cut basically half the questions. And so Ryan, I want to stop there and hand it over to you because I know you've gotten some technical questions about one, like, do I have to go in and change every single question every day? Lots of technical ones. So anything that you want to cover while you have the screen.
Okay, I'm going to kind of start from the start. And of course, when you come in here, this is a different view than what you guys see, of course. This is the master view, so we do see everybody. We're going to give you the next, 3 days, Friday, Saturday, Sunday, after we have everything updated, to go in and play and make sure you guys understand what's going on. So the first time you go in there, you're going to see a blank screen. It's going to go on your COVID-19 survey. It's going to be blank. You are going to go ahead and click Add Entry. And that will bring up your first blank screen. And again, this is our starting point. This is the only time you need to add an entity. After that, you just go ahead and edit everything from within. So I'm just going to do a test here. On my training facility, yours will be locked to which one you are. So if you have multiple entities within your organization, as in your ALS, or not ALS, but assisted living and a basic care facility or a SNF, if you have all three, you will have three different surveys. You will need to do it daily, unfortunately. That is so we can keep our data clear and you guys can keep your data clear too. So as you add your stuff in, you get the wonderful save. So you go through all your tabs, get everything done, and you hit your save. So now the next day, you've got to do a couple changes. So you should only see one or up to three different ones in there. You'll click your edit button. And again, you'll start with your facility name, and we want it to be your actual facility name. We want you to put Parkside Lutheran Home, whatever it is. We want that full name in there so that we can, again, keep good data. You'll go to whatever you need to change and change it. If you have no changes, all you have to do is click any one of these and that'll bring up the save. Once that save comes up, you can hit your save button there. That updates us, lets us know that you went in, you looked at it, and you did your daily. If there's nothing changed, just hit a clock, it's done. I think that is about, I will go over one more thing. So as we're changing these and as you log in and bring up that survey, if you've been in there and done it already, it's gonna sit there and say it's loading, loading, loading. What you do to fix that is on your username, you'll see it up here on the right, your facility name, username will be there. Click on that, click on your profile, then you click on reset settings. Once it says you're done, you can close and that'll clear you out. That will allow you to start from scratch again. That only needs to be done if you're having trouble loading the matrix. And with that, I'll ask if anybody has any questions.
And again, we are coming up to the question and answer portion. So that's actually next on our listing. And let me go ahead and get that process started right now. So if you do have a question, go ahead and dial 855-361-4591, 855-361-4591. Remember, this is not intended to be a way to listen. It's really intended to be a place for people to ask questions or make comments. So if you're joining the phone line, be sure and hit star and then pound. That lets us know that you have a question or a comment to make. So go ahead and dial that up as we start to go around the state now on the video conference line and see if anybody else that's on the panel has any additional comments that you'd like to make while we're waiting for some questions to come in. We'll give this just a moment, and if we don't get any phone questions, we'll move to the written.
Hey, Tim, it's Vanessa.
Go ahead, Vanessa.
I was looking at Ryan's screen there, and I'm wondering, in the past, we had, if a facility had basic care and assisted living, that they had tabs. Was that true, or has this changed now? We're doing previously.
Can I take that one?
Please.
Okay, so I will share my screen again quickly and show you somebody that has multiple facilities. So I know St. Gabe's does. So as you see, when they come in and if they add multiple facilities or multiple purposes, they will have 3 different surveys now. So they'll have again, St. Gabe's has all 3, so they have an assisted living, a basic care, and an SNF. And they will have to fill out 3 of them daily.
Hey, Ryan, we're not seeing the screen. Do you want to make sure that you're...
Sorry about that. I just saw that too. All right. Is it coming through now?
It's on its way. It's up.
Okay. So now you should see 3 Again, this is St. Gabe's, so you should see an ALS, assisted living, a basic care, and an SNF. So they will have to go in daily to each one and update each one individually.
If they are not seeing all 2 lines or 3 lines, should they just email you, Ryan?
If they, yeah, I went off of the list you sent me, so hopefully I got everybody. But if there's somebody missing, yes, they should email me and let me know that I missed something.
All right. Well, I don't have any questions on the phone system yet, so let's go ahead, Shelly and Vanessa, with the written. Oh, I take that back. We do now have someone on the phone. Go ahead, caller. Go ahead, caller.
Hi, can you hear me?
We can hear you.
Okay, I just had one question about having the assisted living and basic care together because the staffing is not separate.
So give me a little bit more. I don't think I'm quite grasping your question yet.
I think
Okay,
she's asking if her staff is shared, is what I'm assuming, correct?
Staff is shared, so you're asking for separate beds for basic care and separate beds for assisted living, and then different staffing questions for each one, but the staff is not separated. The staff take care of all of
So there
the
is no
residents.
more staffing questions within the
staff.
survey.
Okay, all right, thank you.
Thank you. All right. We don't have anyone else on the phone, so Shelly, Vanessa, let's go ahead and proceed with the written questions.
Sure, maybe I'll begin the first one because I think there's still some confusion with it. And you all should have received the document and there are answers to them. But the first question, what is the standard for recovered resident? 2 negative tests or 14 days without symptoms since diagnosis. And I know Roseanne just talked about 10 days since a testing. The response there that they gave, I'm sorry, Vanessa and I just noticed that the response is in reference to staff. And in regards to staff, the CDC guidelines are facilities can choose one of 2 strategies, the symptom-based or the test-based. But going back to, there may be, I know that there are questions on staff too, but first for recovered residents, is it, and maybe phase on, is it 2 negative tests? Is it cleared in 10 days or is it 14 days without symptoms? We're still having some confusion on that. And Faye, I'm not sure if Faye's on the line or if someone from disease control.
The 14 days is for incubation period. So if they are not a case, but they've been exposed to a healthcare worker or another fellow resident, like a roommate, that is still 14 days. The incubation period of the virus has not changed.
So then, for clarity, recovered, because facilities put it on their websites too, how many are recovered. What is the definition of a recovered resident? And is it 14 days without symptoms, or could you get 2 negative tests? Or I'm confused now on, maybe I didn't hear Roseanne correctly, the 10 days they automatically would come off the dashboard.
Well, Roseanne is talking about the asymptomatics. So if you have somebody that's asymptomatic, but then they develop symptoms, we have to just think about, and maybe case by case individual, if they become symptomatic, just because their 10 days are up doesn't mean you're going to let them back. So what Roseanne was talking about, it was for the recovered numbers for the website.
Right.
That doesn't mean we're going to blanket 10 days on everybody, and whether they have symptoms or not, they're considered out of incubation or out of recovery, or they can come back to work situation. So those are 2 different scenarios.
Right, and I guess I didn't catch the asymptomatic. So then, well, that makes more sense. Issue then on we do have some employees that are continuing with their symptoms. So as long as they continue with symptoms, they're still considered. They need to not be working, and they're not working. But then on the website, we have different data. I mean, I loved it when Roseanne said those are the asymptomatic ones. Asymptomatic ones are, I mean, that's still confusing to me. If we have only asymptomatic, maybe Roseanne can clarify, because I'm
If they're asymptomatic, we use the test date 10 days from. If they're symptomatic, we use their onset of symptoms to go 10 days from.
okay.
That is for
So
taking them as recovered for the data process of the dashboard, because it's hard to track that.
Right.
But actual, for facility purposes, whether they're going to consider them coming back to work, they still need to look at if their symptoms are resolved. So it's really hard to compare those two scenarios.
Okay, no, and we were thinking more residents on that. So just to clarify, rather than I'm probably just confusing myself, on the dashboard where they will just automatically rotate off anyone that is it just asymptomatic. Will you even know the difference between those that are on the dashboard that are asymptomatic versus those that had symptoms? There'll be a different definition on when they're taken off the dashboard, or is it just we're going to make the assumption that residents and staff are recovered based on that time frame of 10 days, or do you have precise information differentiating between those that were symptomatic and those that were asymptomatic?
Shelly, I think you may be confusing yourself, but you're getting me confused.
I know.
So, dashboard scenario, okay? We're talking just dashboard now. We are going to go 10 days from their symptom onset, their test date of asymptomatic, period, okay? What I'm saying is that doesn't mean the should take them out of isolation or let them come back to work.
Yeah.
To look at if they're still having symptoms.
Right, and I think everyone gets that. I think everyone knows that and is following that. It was just the sensitivity of what's on the dashboard and having that be an accumulative number. We're extremely excited and pleased that it's going to be now active cases. And I think as we see that, hopefully tomorrow or early next week, we'll better understand that information on there.
All right, let's go ahead and move on to the next question.
And the next one was Kathy had responded. It was, please clarify if the website posting that lists new confirmed cases of COVID-19 for staff and residents comply with the notification requirement for CMS requirements. Website postings are done at least weekly, most of the time, each time there is a new staff confirmed case. And Kathy, you had answered this?
When I answered this one, I said to refer back to that memo dated May 6th, the QSO memo 2029. It does talk about different ways of reporting that you can, but if you look at the very last sentence there, and I underlined it, the facilities are expected to take a reasonable effort to make it easy for the residents. And it's also the facility's responsibility to provide that data. I don't know if a lot of people are using those other reporting ways. I can't think of what that's called, Shelly, that you guys use for reporting to to families. But I don't know that you can just depend on the state dashboard, the state website. I think it's the facility's responsibility to report to their families, because it does say it's got to be reported within, I think it's by 5 p.m.
Kathy, I think this question, they were talking about their own website, if they reported on their own website.
Well, I thought I was kind of unclear if it was the state website or their own. Well, and I think it doesn't reference their facilities of, email listservs, website postings. You know, it does give you some examples there. If you read that memo on that second, I think it's on page 4 under F885. You know, you don't have.
I think, Kathy, I think in there it says very clearly that your website can serve as a purpose to update, inform families.
Right.
Yeah.
I thought maybe they were referencing the state dashboard when I first looked at it.
Okay. Okay, the next question then, why don't we go on to, can a resident or a staff member refuse testing? We've talked about this in the past. HCA had sent out some guidance saying, yes, residents can refuse COVID-19 testing. You can't involuntarily discharge them if they say they're not going to be tested. You can't require it. They do have the right to refuse it. And I know Faye had given some guidance about, well, then maybe you need to assume they're COVID positive and treat them that way since they refuse to be tested. The other issue on employee refusals, we do have, I know, at least one company that is making it a condition of employment, and HCA came out with guidance this week affirming that, yes, as an employer, you can make that determination and make it a condition of employment, or not hire someone that refuses a COVID-19 test as a pre-employment. So that has been affirmed. You can do that, as well as employees can refuse, and you as a company, if you allow that, that is I guess that's up to you as a company.
All right, this would be a good time to dial the phone. We have no one on queue right now, so dial up 855-361-4591. And Shelly, we can go to the next written.
And I think the next one was in the issue on the VP3 plan, and it says a resident was sent over for chest pain to the ER. They're admitted for an observation overnight. Does the resident have to be COVID tested in order to return to the facility? Chris, are you still on? I know we had that discussion this week with hospitals. What if that same person is admitted for observation and they're kept for 3 days? So it's an issue on testing in the hospital. And if Chris isn't on, Chris, are you there? Chris or Roseanne? Generally, what we talked about this week then is the expectation is anyone that's in the hospital would be tested upon discharge back to a long-term care facility or upon a new admission to a long-term care facility. If it's an ER visit, that's probably not realistic. They're in there maybe for a couple of hours. The testing would delay that. Most definitely, if they're in for overnight in the hospital, the expectation is prior to going back to your facility, you'll get that data and testing.
Great. Well, let's go ahead and head to the phone now. We do have a caller. Go ahead.
Hi, I was wondering, we have a resident here that posed a question. If they have a family or a friend that passes away, and they want to go to their funeral, what kind of guidelines and rules do we need to follow for that?
All right. Does anybody have any guidance that you would care to provide?
think Faye has addressed that in the past. Faye, are you still on? Can you address it?
Faye, are you with us? Kathy, do you want to try and take a stab at it?
I know Faye has talked about this in the past. And I think if the rest of you on the call too want to, but I think if they wear a mask, hand hygiene, limit their exposure to other people at the area. And I think also what's starting to play in our state is that the area of the state you're in too. Any other, Shelly, do you remember any of the other things that she's talked about?
I do see that she has kind of addressed it in number 5, because it also talks about going to church and going to the cemetery this weekend. And it does talk about those things that you say, wearing a mask, proper hygiene. And then I think it also talks about isolating away from the other residents for 14 days after they return.
Yeah, I think the key is, a mask, hand hygiene, maybe some more monitoring. It depends how many times you're monitoring a day now, but some more monitoring of the resident.
All right. Thanks, Kathy. I know that I think we're a little bit reluctant to speak on Faye's behalf is part of the issue. And because this does seem to be in we know that the transitions are afoot, I think a little of us are concerned about weighing in. And my recollection is that there was a call for, however, the 14-day isolation upon return and to maintain the social distancing while that resident was out. But again, that was passed going back several weeks. So I think we're just going to defer that with the way we have it right now and see if Faye has some additional guidance that we can follow through following this. Let me see if we have anyone on the phone right now. Anybody on the telephone? We do not have anyone online, so let's head back to the written questions, Shelly.
I think the next one is the same as it's the visitation issue that we get into visitation. They want to go back to church. Faye has put in there that she's not sure what the recommendations will be going forward because we do have that visitation committee that we're going to try to get consensus and guidance. However, she does put in based on infection control standpoint. So just look at that answer in red or black if you have it, and it gives the direction. And then the PPE, the next question again was a big question, and the facility was asking if a facility has to start wearing eye shields or face shields at all times, how often can the face shield be worn? Is there a certain rotation or the same one every day, and clean it before and after your shift? His response is face shield goggles should be dedicated to employees, so each employee should have their own and should be disinfected daily when it becomes visibly dirty. Tim, the next question is yours. We received a shipment of cloth masks with silver and copper from FEMA. Is there any guidance on how these are supposed to be used? So cloth masks, Tim.
Yeah, so there are the distribution from Health and Human Services, and also Homeland Security has been doing some distribution. In a medical environment, and we consider long-term care that medical environment, in terms of the actual staffing, we would recommend that you utilize the medical grade PPE that is in fact in the medical cache, and that is available to you. There are some areas where there are recommendations in terms of the residents, and there will be a question coming up about that shortly, about when residents would be wearing masks, and CDC has made some recommendations about residents wearing cloth masks. But in terms of the actual staff, that really is more in tune with what the medical grade is that's still available from within the medical cache. I'd also add that if you do have N95 respirators that have been utilized, please do not discard them. Please follow the guidelines that CDC has issued for storage of those, and please sign up and get those sent into the Battelle decontamination process. We really want to recycle those N95 respirators. We have not been successful in restoring those back into the medical cache, and so it's important that we do in fact do that decon process. And the address for that is www.battelle, BATTELLE.org, and that's where you can sign up. There's no cost to your facility, either for the shipping or for the provision of the service, and those masks that you sent in will be sent back to your facility. All right, Shelly, next.
And Tim, the next one had responses as well. So I'm thinking, since we're hitting a little bit after 2, let's look at these responses. There is lots of concerns about do residents need to wear masks if the staff person is already wearing a mask in the room. And the CDC guidance, as Tim said, is that if residents can tolerate it, they could wear the mask, the cloth mask in the room if they can tolerate it. Next one, and I know having worn a mask, I can't imagine how hot at the end of the day it's got to be, and it just physically wears you out. Staff are wondering about discontinuing masks at work or even the face shield, because residents are complaining that it's too hard to understand, and resident staff are getting very uncomfortable with rising temperatures. We have the summer coming. I know Faye's response is the recommendations remain in place. And listening to Dr. Stahl and listening to the fall, I don't know if, I think this is something we're going to have to learn how to tolerate. The next one, resident care. We're having challenges with getting the residents to receive communion. We have a Eucharistic minister on staff and is willing to distribute communion. They're wondering, can we reach out to the bishop? I don't know if this is a Catholic. If everyone has bishops, we have a bishop in the Catholic. What we do is probably reach out. I don't know if everyone is having an issue with this. Tim, do you have any thoughts on that?
My only thought is that we certainly can do an outreach and pose the question, and we'll do that and bring some information back. I know that multiple religions have bishops, so Protestant faiths also have bishops, and we can just initiate those contacts and see what type of a written response we receive from Catholic and some Protestant representatives.
Thank you, Tim. The next question was clinical rotations with nursing staff and their need to have clinical rotations. It sounds like there's some that want to start up this summer and allowing nursing students to do their clinical rotation within the facility. How safe is that? Can we do it? Are they considered essential personnel? If we don't educate our nurses, it's going to be really essential. She has a response there, and she says, a lot is going to depend on reopening up nursing homes, other facilities. So I guess if you have, I think what might be best, Tim, is if there's a specific facility that wants to open up their facility for clinical rotation for nursing students, probably reach out to Faye. Tim, is that the best way to look at what's occurring and what might be safe and best?
So since I don't think Faye is actually online with us right now to defend herself, I think that's an excellent idea. But beyond that, if Faye can't answer or isn't available, we'll handle it within the department. But go ahead and reach out to Faye. We'll leave it at that for now, and then provide a response back.
Okay, the next one is miscellaneous questions. The CMP Reinvestment Communication Technology Grant. CMS developed an application template and is offering up to $3,000 for facilities through the CMP Reinvestment Fund in each state. How long does it take to receive word if we receive funds to make purchases? Kathy, and I think this is different from, we had sent out an invitation from North Dakota Assist, and they have received some grant funds, and I know we've had at least 40 facilities sign up wanting to be part of that grant program. And they're trying to get everything in line with what they need in order to distribute funds. So if you have not yet signed up for North Dakota Assist, those grant funds, let us know. Kathy, are there additional funds available through CMP money that we have sitting at the state?
So I can address this. So we've been having meetings. We had one again today with the grant money that's available with North Dakota Assist. Carla from the Ombudsman's Office, Aging Services, and myself. And we're looking at the funds that are available and trying to figure out and go forward with a plan on how to best use that for residents and facilities. There is, and I have gotten some applications from facilities on the CMP reinvestment grant. That is up to $3,000. So what I can say right now is we are working on it. I don't have a timeline. We're hoping to get some more information later this week and no more next week. Hopefully by the next Thursday's call.
So Kathy, just to clarify, there is the reinvestment technology grant as well as North Dakota Assist. So there are two avenues for funding?
Yeah, there are.
Okay.
But the thing with the CMP money is that is only for skilled facilities. Right. So we're trying to, like I said, figure out the best way to use those funds, because if the basic cares have a need, we may have to go through the assistive North Dakota Assist or the other grant.
Okay.
And if I can chime in here, I'm aware of that question. And the reason it was brought is because the facility had applied through the CMP grant and not through North Dakota Assistive. So the question was, hey, that they just went through the CMP application process. We're skilled nursing.
Say that again, Vanessa.
If they're skilled nursing and they applied through you, through the CMP, or sent the application to you, do they have to apply through North Dakota Assistive as well, or is that one application fine? Well,
if they want to apply through the CMP process, yes, they have to send me the application. I'm not sure on the other side what they have to apply for.
You know, and at this point, Kathy and Vanessa, I think what would be best is have facilities apply for both. And at this point with North Dakota Assistive, they're just taking your name and contact information. Right. But I'd hate to have you miss out on an opportunity. So if you need and want some technology-free money, go back and look at North Dakota Assistive, get your name on the list. And then if you want to, as a nursing facility, also apply under the CMP technology, visit with Kathy on that grant application process. You could go into both. I would think, though, the health department, who is involved in both of the initiatives, because there's only a limited amount of money, will try to spread the money to as many facilities as possible. But I guess it would not hurt to have your name in both places, especially since one is simply just getting your name on a list at this point.
Yeah, it's fair to say that we have visibility of this. We want to try and get the most funds distributed. We are. The department, I think it's fair to say the health department is supportive of this project and wants to see it funded. So it's a process of just moving through the applications and keeping the process moving forward. I would completely agree, though. Apply for both, and then we can align the eligibilities and see if we have any shortfalls.
Well, and that's why we wanted to that's why we got together as a group so that we could determine who would qualify for what, you know, and if it, for the CMP, it is only for skilled. So that's why we have that. And then the grant could be for other facilities. So we're still working. Like I said, we met today to discuss it.
Thank you. The next question was employees. And as you know, it's the Memorial Day weekend. People in eastern North Dakota have absolutely wonderful Minnesota lakes to go for. And there seems to be a little bit of confusion about employees that live in North Dakota, work in a North Dakota facility, and they go to Minnesota lakes without being isolated for 14 days. My understanding, and you'll see Faye's response, is they're exempt from the order. So I don't want to say we don't need to worry about it, but just make sure your employees are observing, the social distancing, hand washing, small groups, because just as we're all needing to do that no matter where we go. But I think there's been some confusion on that. My understanding is they can go to their Minnesota lake home, but we all just need to be smart about what we're doing. They wouldn't need to be quarantined when they come back. Tim, do you understand that any differently?
Nope, that is my understanding as well.
Okay, great. The next one is, can a North Dakota Medicaid recipient pay for an outstanding dental medical bill from her stimulus check? I think I sent that guidance out to you. It's the recipient's money. They can choose to use their money however they want. Unpaid bills, medical bills, outstanding RL, owed to a nursing facility. They can use it for any purpose. So visit with your residents, see how they want to spend their money, use their money. And it's a great opportunity to pay up some bills if they've had some outstanding medical bills, if they want to. And that's outlined on there. I think that that is the end of our questions, Tim. I don't know. I'll turn it back to you.
No, that's perfect because it's also the end of our time. We have no one else on the phone. And so, Shelly, do you have any closing comments?
Well, just to say thank you, guys. I know it's been tremendously stressful. We know that this is going to continue for a while. I have high hopes with Chris Larson leading us in our visitation policy. So more good things to come on what we can do and having a good positive response to families and opening up visitation safely. I hope all of you get a little bit of relaxing this weekend. I know that's hard for you because you're on call 24/7. But thank you for all that you were doing in keeping your staff and residents safe and enduring this long process.
And let me just see if I know that Chris was with us earlier. Chris Larson, are you still with us? Unfortunately, Chris,
Yes.
no, I'm sorry, Chris did leave. So we'll have to take another opportunity to introduce you to Chris, a phenomenal individual. Kathy, any closing comments?
I'd just like to thank all the facilities for everything they're doing. I know it's been kind of a stressful week. We've had some positive cases show in some facilities. And if you do see our surveyors come to your facility, we're still doing these infection control focus surveys. And we're there to help you to look at your building and your setup and how you have things, to give any advice that we can, and just kind of help you problem solve through things. I know we have been doing some of those surveys. So we just like to thank you all for welcoming us to come in and to help you go through this difficult process.
Thanks, Kathy. Vanessa, any closing comments?
Nothing for me, but thank you, everybody. You've been doing a great job.
And I'll echo that. I hope you do have an opportunity this coming weekend, extended weekend, to get some rest, and we'll be back with you again next week. Take care, everybody.